Yeah, very good evening, my dear friends and professional colleagues. And this is Dr. Sepuri Krishna Mohan, endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. And thank you so much for Novonades people for giving me this opportunity to be the speaker of this evening. And thanks a lot, Satish, for your kind introduction. And let us get into the topic. And the topic today is the fulfilling dual glycemic needs, the initiation of insulin for the management of diabetes in the Indian context. And this is my financial disclosure. And today's agenda is being divided into three parts. And the part one is the management of diabetes mellitus in India, the realities. The inertia, that is insulin inertia, especially the bridging the barriers and simplifying the insulin therapy, initiating and optimizing and intensifying insulin with the same insulin. So now coming to the part one actually. So as all of us know that the burden of in India as far as diabetes is concerned is terrible. It is growing in abnormal proportions and as of 2019, according to the International Diabetes Federation Atlas, clinical atlas for diabetes, it is the number suffering from diabetes in India is around 77 to 78 million people, and all over the globe it is around some 440 million people all around the globe. And the core message here is 4 in 5 people with diabetes are uncontrolled. And we can very clearly see on the left hand side an article published in the Indian Journal of the Endocrinology by Professor Mohan and all other stalwarts in the country. The current status of management, control, complications and psychosocial aspects of patients with diabetes in India, the results from the Diab Care India 2011 study, and the number of subjects included were 5,907. And this clearly shows that the people suffering from type 2 diabetes having a reasonable HbA1c according to the American Diabetes Association, the goal for the HbA1c, the glycosylated hemoglobin, around or less than 7 was only 19.7%. That is less than 20%. That is the reason why I said 4 out of 5 they remain totally uncontrolled as far as diabetes is concerned, especially in our Southeast Asian context, that is Indian subcontinent actually. And the second reference we get this, the latest one as recent as 2019, which is published in the British Medical Journal Open Diabetes Research and Care, that the title being the real world evidence of glycemic control among the patients with type 2 diabetes mellitus in India. This is called the TIGHT study actually. That showed a little bit improvement with 23.4% of the patients suffering from type 2 diabetes, they had A1C of less than 7. So on the right hand side you can see this triad. The IDCI is nothing but India Diabetes Care Index, and this is an innovative study done by Novo Nordisk itself, the pioneers in the field of insulin all over the globe. And according to them, the fasting was somewhere around 176 milligram per deciliter, and the postprandial glucose was around 251. So it is terribly out of control, because we require to be like as far as the recommendations of American Diabetes Association or the American College of Endocrinology or the American Association for the Clinical Endocrinologists or the IDF or the European Society for the Study of Diabetes, the EASD, European Association for the Study of Diabetes, we need to keep a tight control like the fasting plasma glucose must be at any cost, it should be in between 80 to 130, whereas in the real scenario in India, according to the India Diabetes Care Index, it is 176. And according to this same guidelines, the postprandial glucose or any time other than fasting should be less than 180 milligram per deciliter, and it is terribly high, it is 251.33 milligram per deciliter. And according to the ADA, the HbA1c, the glycosylated hemoglobin, should be less than 7, around or less than 7, or 6.5 to 7, and now it is the 8.48%. That is all the glycemic triad. This is called the fasting plasma glucose and the postprandial plasma glucose and the HbA1c together are called the glycemic triad. The entire glycemic triad is terribly out of control according to the study done by Novo Nordisk, that is India Diabetes Care Index. And only the inference is the only 22% of the people with diabetes they have an HbA1c of less than 7, and the subjects included were it's around 21,000. It's a huge population, massive population. And this is a bar diagram showing the Indian reality, what is happening about the diet with regards to the consumption of carbohydrates as well as proteins as well as the fats. That's what the different parts of the country, like East India, the West India, the North India, the South India, the Central India, you can very clearly see that the red color or the saffron color that denominates the intake of carbohydrates, and the blue is protein in the middle, and the green is fats. You can very clearly see there is no difference. There is only a marginal difference between the high consumption of carbohydrates in our day-to-day food consumption in different parts of India. All over the country, it is somewhere around, you can very clearly see the less of proteins, the more of carbohydrates is the culprit in our party. And 61 to 70% of the energy intake in Indians is through carbohydrates in the diet. So why this high carbohydrate diet is very, very important? Because high carbohydrate diet, when compared to the moderate or low carbohydrate diet, that leads to the increased postprandial glucose, which in turn leads to the atherosclerotic cardiovascular disease. That is, the incidence of high carbohydrate diet leads to the increased mortality rate via increasing the postprandial glucose, which is a direct cause for this coronary vascular disease, that is the cardiovascular disease, or nowadays the term is atherosclerotic cardiovascular disease, ASCVD. So we need to modify this, like what in my experience I would suggest is let us make this carbohydrate intake to 40%. Instead of 60 to 70%, we make it 40%, and the proteins 30% and the fats 30%. That will be a nice combination, ideal combination, not only for the patients suffering from diabetes, hypertension, or dyslipidemia, or the coronary artery disease, or the strokes, whatever it may be, even for anybody who wants to be healthy and maintain the quality of life. And the statistics and all is about the more is the carbohydrate intake, the more is the associated risk of mortality. That's what I was talking about. The more the carbohydrate intake, the more the mortality. That's I have told you how it increases the mortality, because it increases the postprandial plasma glucose. Thereby it contributes to the increase of HbA1c. Thereby that leads to that acts at the level of carotid intima medial thickness. So that leads to this particular the cardiovascular problems, and the mortality is very much increased. And 17% significantly higher mortality in those who consumed higher carbohydrate diet versus moderate carbohydrate diet. And we know that Indian diet is somewhere around 60 to 70% of the energy intake is only through carbohydrates, whereas the Western diet, that is the United States of America or the Europeans or the rest of the world, they are taking only 39 to 47% of energy through carbohydrates. That is the difference. Why the one heart attack is recorded in the United States and we are recording 4 heart attacks. One case of stroke is recorded in the Western scenario, US and the Europe. We are recording 4 cases of this particular the strokes. So also with the cancers. See, we are ahead all over the globe as far as the diseases are concerned, like the lifestyle diseases, maybe diabetes, maybe hypertension, maybe the coronary artery disease, maybe the stroke, maybe these cancers. We are heading the globe. And the clinical implications of high postprandial glucose and the macrovascular complications. See, I mind you once again, it doesn't produce only the macrovascular complications, it has impact on even the microvascular complications also. As you are all aware that the macrovascular complications are again the coronary artery disease and the strokes and the peripheral vascular disease or the peripheral arterial disease, that is PVD bar PAD, PAD. So this is not related to only this, the contribution is more towards this particular macrovascular complications in terms of recording the highest incidence of mortality in terms of the heart attacks and the strokes, and this also the high postprandial glucose is related to the high carbohydrate diet, in turn leads to this high postprandial glucose, in turn leads to, which contributes to the elevated HbA1c levels, that leads to even the microvascular complications. Per se, the retinopathy incidence is increased and the neuropathy is increased, as well as the diabetic kidney disease. Earlier we used to say it as nephropathy. Now the latest term is diabetic kidney is also increased. And these are all the various studies which have shown that the high postprandial glucose is very hazardous. Like postprandial glucose, a risk factor for increased the carotid intima medial thickness in non-diabetic individuals. That's what I was telling in my earlier slide. The death is because of this particular the risk factor for increased CIMT is coronary intimal medial thickness in non-diabetic individuals, and the result is that the post-meal hyperglycemia exerts a harmful impact on the carotid intima medial thickness. And the second is the Hone study. The 2-hour post-load glucose level is a better predictor of risk of all-cause and cardiovascular mortality than the HbA1c. And this is the third is the most popular study, that is Honolulu Heart Program, which was a landmark trial which clearly showed that there is a linear relationship noted between the post-challenge glucose and the fatal congestive heart disease and the non-fatal myocardial infarction. And the Chicago Heart Association study, it has shown that high postprandial glucose levels are increased with the risk of cardiovascular disease and mortality. I have been telling you this is the important factor, the increased postprandial glucose because of high consumption of carbohydrates is the culprit with regards to the cardiovascular disease and the mortality. And again the another study, the diabetes intervention study, the 11 years follow up, the post-meal glucose level is associated with coronary heart disease. And the last one is the incident cardiovascular events and glucose level, a meta regression analysis actually that showed the 2-hour glucose is associated with cardiovascular event risk. So we have got lot of robust, ample evidence-based medicine showing all the major studies showing that the high carbohydrate intake is inversely proportional to this particular the increased mortality via increasing the postprandial glucose, via increasing the HbA1c levels, via the thickening of the narrowing of the carotid intima medial thickness, and leading to the cardiovascular disease, that is nowadays we call it the atherosclerotic cardiovascular disease, ASCVD, and the increased death rate because of the heart attacks and strokes. ASCVD that includes both the heart attacks as well as the strokes. So the inference of this particular the studies we have mentioned, the cardiovascular disease and the mortality are associated with postprandial hyperglycemia. And apart from this Honolulu heart program, there are another 7 major studies which have clearly said that the postprandial glucose is directly related to the increased cardiovascular deaths. And clinical implications of high postprandial glucose, and now comes the question of the microvascular complications of diabetes, being the retinopathy, either the NPD or non-proliferative diabetic retinopathy or the proliferative diabetic retinopathy, any degree of retinopathy to some extent, and the diabetic kidney disease, starting from again it is diabetic kidney disease is staged like stage 1, stage 2, stage 3, A, B, stage 4, stage 5, based on the calculating the estimated glomerular filtration rate. You please never go by the serum creatinine, which is a very decisive biochemical marker. Don't go by that. All the time you calculate this particular EGFR, estimated glomerular filtration rate, because if you don't calculate, you will not be able to stage the chronic kidney disease, that is diabetic kidney disease or the diabetic kidney failure. So the clinical implications of high postprandial glucose with regards to microvascular complications. The prevalence of the vascular complications was assessed in South Indians with non-insulin dependent diabetes mellitus. There is no longer this term, but this is taken as long as dated like I think it's 1999. I think this slide was from 1999 actually. So they use this particular term NIDDM, the non-insulin dependent diabetes, which is now been transformed into type 2 diabetes, and over the 25 years of duration of the diabetes. And you can see on the right hand side the nephropathy, the dependent variables are nephropathy and neuropathy, and the variable tested is the postprandial glucose, and you can very clearly see the odds ratio and the p-value, which is very statistically significant. So that is, there is increase in the incidence of the nephropathy, the diabetic kidney disease, as well as the neuropathy is also increased. And coming to this particular retinopathy, the variable is postprandial plasma glucose, and the no retinopathy was somewhere around the 253 individuals plus or minus 76, whereas some degree of retinopathy, whatever it may be, either the stage 1, that is called the non-proliferative diabetic retinopathy, or the stage 2, this particular the proliferative diabetic retinopathy, or the macular edema, whatever it may be. See, it was 298 plus or minus 92, the p-value being 0.001, that is statistically very significant. And the inference is the postprandial hyperglycemia is not only associated with this particular increased risk of macrovascular complications, it is also related to the microvascular complications and the increased risk of diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy, especially in Indian people suffering from the type 2 diabetes mellitus. And this is a bar diagram showing unlike the Western population, postprandial glucose should be controlled at all levels of the HbA1c in Asians. This is the picture in the Asians actually. So the dark blue one is this is the postprandial glucose, whereas the grey one is the fasting plasma glucose, and whatever be the HbA1c, you can see the HbA1c on the x-axis less than 7.1%, and the second is the 7.1 to 7.5, and the third is 7.6 to 7.8, and 8.1 to 8.7, and 8.8 to 12.7. Whatever be the HbA1c, you find either the increased postprandial glucose or the decreased, the reduced postprandial glucose, but still there is, according to this Moner et al., the higher contribution of PPG at lower HbA1c levels are similar to the Caucasian data. That's what the inference of the Moner and et al. And the evidence from the Indian studies, the high postprandial glucose and the high HbA1c. Here you can very clearly see on the different the bars, that is the same. The dark blue is the postprandial glucose, and the grey is the fasting plasma glucose. And according to this, the India Diab Care study, that is IDCI, and the Diab Care, where the A1C was 8.9%, and A1C achieved, that is 9.2% A1C, and the present study where the A1C was 9.2 and improved 9.3 respectively, and we can very clearly see that both the fasting and the post lunch blood sugars, postprandial blood glucose was terribly high, like irrespective of the A1C levels actually. So you can see the least being 8.5, the fasting is around some 170, the postprandial is around 156, whereas the same improves shows with a glycosylated hemoglobin of 9.3, the fasting being 192, the post lunch being 279, and the inference from this particular bar diagram is that the uncontrolled glycemia in India demands timely treatment and optimization and insulin therapy. Because I'm terribly sorry to say this, insulin is being very underused in our country because of the apprehensions in the medical fraternity actually. You don't need to worry about initiating insulin or optimization of this insulin or intensification of insulin. It's an art. It's very easy. You can learn it from your seniors. Senior colleagues will teach you, and if you follow such the CMEs, you'll be able to clarify all of your doubts. You can just get rid of your apprehensions regarding the initiation of insulin, optimization of insulin, and the intensification of the insulin dosage using the same insulin, whatever it may be, either the biphasic premixed insulin, human, that is even this particular the biphasic protominated insulin aspart 30, whatever it may be, you can initiate, you can optimize, you can intensify. So uncontrolled glycemia in India demands timely treatment, optimization and insulin therapy, and where the insulin is like mandatory also, majority of the prescriptions I am seeing, they are prescribing only the orals. See, according to the recommendations of either the American Diabetes Association or the American College of Endocrinology or the American Association for the Clinical Endocrinology or this particular the International Diabetes Federation or the European Association for the Study of Diabetes, once the HbA1c is around 9 or above 9, it is mandatory that one should start insulin with or without the existing OADs. That is left to your discretion depending upon the condition. Suppose the patient is in DKA, you have to withdraw all, you have to use only regular insulin. Suppose the patient has got infection, he is bedridden, okay, you can use the basal bolus regime. the patient is in the ICU setup, you can use this particular regular insulin with a basal insulin if at all it is required. If the patient is in a non-ketotic stage. So, coming to the next slide. And we have finished the first part of our agenda, and coming to the second part, that is the main part, the insulin inertia. See, this is not only the insulin inertia. Inertia is like divided into several categories. It is the clinician's inertia, the clinical inertia, the therapeutic inertia, and the patient inertia. It is divided into so many categories. The inertia is from the clinician, the inertia is from the patient. So at multiple levels you have got inertia. We need to overcome that inertia. This is related to insulin. The topic being insulin, I have to talk about insulin, but it refers to all categories of treatment. There should not be the clinician's inertia as far as the usage of drugs. The right choice of the drug at the right time, at the right dose, to the right patient. That's what anything is best in its place. So this is about bridging the barriers. And now you can clearly see this. So the graphs are missing actually. So this is about the achieving glycemic goals by timely treatment optimization. The see, there are two graphs actually. I'm not able to show you in my tab actually. So the light blue is the sequential therapy approach, and the dark blue is early combination therapy actually. And on the y-axis you see the glycosylated hemoglobin, and the x-axis you see the duration, the time of diagnosis of type 2 diabetes after 5 years, after 10 years, after 15 years. And to start with, diet and exercise and the OAD monotherapy, like we start generally with the metformin. The treatment of type 2 diabetes starts with metformin unless otherwise metformin is contraindicated. And of late, the recommendations have been changed by the European Society of Cardiology and the European Association for the Study of Diabetes, that if it is a case of atherosclerotic cardiovascular disease, or at the risk of the patient is at the risk of developing atherosclerotic cardiovascular disease, or the patient has got established atherosclerotic cardiovascular disease, even the patient is detected for the first time with or without metformin, you can straight away go to either the GLP-1 receptor agonist, where the 3-point MACE is very much predominant, and you have to use the SGLT2 inhibitors if this heart failure predominates. So you can combine both if there are two components, because to the best of my knowledge, as far as this cardiology is concerned, 90% of the heart failures are just because of the heart attacks. Without a heart attack, you cannot expect a heart failure. And rare cases are there, like dilated cardiomyopathy, or this particular the ischemic cardiomyopathies. They say, barring that, most of the times are anemia inducing this particular. The commonest cause of heart failure in our country in females, it is the anemia, the severe anemia, hemoglobin somewhere around 6% or less than that causes heart failure even in the absence of heart attacks. So this is a schematic representation that shows if you go by this diet and exercise, OAD monotherapy up titration, that's what we start with 500 mg milligram metformin. Then after 1 month we increase it to 500 mg BD, and after that we go to the 1000 milligram in the night, 500 in the morning. Again after 1 month we go to 1 gram in the morning, 1 gram in the night. By then the patient will land up in either DK or something else, whatever it may be. So the sequential the therapy approach is not fruitful, and you need to be like go for this particular the blue line which shows the early combination therapy with or without insulin. That's what. And the indication for insulin is per se, if the patient is on 3 oral anti-diabetic agents, 3 OADs, and if the patient is still not to the target, either the fasting plasma glucose or the postprandial and the HbA1c are not to the target, it's high time you have to start insulin along with this particular three OADs. Preferably we start with the basal insulin or the biphasic premixed insulin or the designer analogs have come. Even the co-formulations also have come. So the depending upon the pocket of that particular patient, you can choose from the basket of insulins from Novo Nordisk. It caters to all the needy patients who badly require insulin. Starting from 158 rupees, the biphasic premixed, you have until 1320 the co-formulation, that is insulin degludec and aspart. In between you have the insulin the biphasic aspart 30 also you have, and you can never achieve in the light blue, you can never achieve this HbA1c of 6.5 to 7, whereas with the early combination therapy, that clearly shows that particular levels reaching to 6.5 to less than 7 most of the times. Even after 5 years after the diagnosis, 10 years after the diagnosis, or even more 15 years after the diagnosis. And here I would like to highlight one basic issue, the natural history of the disease. By this is postulated by my mentor Ralph Anthony DiFranco. He says by the time it was an older version, I am telling you. The old hypothesis what he postulated was by the time you diagnose a case of type 2 diabetes, more than 50% of the beta cells are dead. So only 40 to 50% of the beta cells are functioning. They are going to secrete the insulin, and body is little bit deficient of insulin. And the other theory is that we have got insulinopenia along with insulin resistance, that is some sort of insulin corruption that is not being utilized properly, though there is a proper secretion, because of the insulin resistance at the level of muscle, at the level of fat, at the level of liver. So now the recent postulation in 2013 actually by same Professor Ralph Anthony DiFranco is that by the time you diagnose a case of type 2 diabetes mellitus, more than 80% of the beta cells are dead. So there are very less functioning beta cells, and when the beta cell rate goes below 25%, the functioning beta cell percentage goes below 25%, no oral anti-diabetic agent is going to act on that particular type 2 diabetes patient. Insulin is mandatory. So this is one funda where you have to start insulin. And second is, I have told you, where the patient cannot achieve a reasonable glycemic control, either the glycemic triad, glycemic pentad, glycemic hexad, you have to start insulin along with the existing OADs. And the third point is that you should start, if the HbA1c, you should start inevitably the insulin if the HbA1c is around or more than 9% of HbA1c. So going to the next slide, and this shows the comparison between the Pima Indians, where the Pima Indians are near the near the United States of America. You find the Pima Indians and the Red Indians, and then the blue is the Pima Indians, and the orange is the Asian in Indian actually. So the Pima Indians are known for their insulin resistance. They have got severe insulin resistance, whereas we Indians the real Indians, we have got the insulin resistance as well as the insulinopenia also. We are running badly short of insulin. At the same time, the background of this particular the pathology of type 2 diabetes includes the insulin resistance also. Whereas the PIMA Indians, they have got sufficient insulin, but they are badly suffering from this severe insulin resistance. See, on the right hand side, on the left hand side, you can see the glycemic status. With they compare it to this PIMA Indians and the Asian Indians. That is, you on the y-axis you can see the fasting insulin actually, and on the right hand side you can see this the natural course of diabetes. That's what I said. And both the sides, left or right, you can find the normoglycemia, and that leads to IIFG, that is isolated impaired fasting glucose, and IIGT, that is isolated impaired glucose tolerance, and impaired fasting glucose plus impaired glucose tolerance put together is called pre-diabetes, and finally diabetes. This is the natural course. The patient will be normoglycemic, and slowly he eventually develops a stage called isolated impaired fasting glucose, and later on, that is isolated impaired fasting glucose is nothing but the blood glucose in between 100 to 125 is categorized as isolated impaired fasting glucose, and on OGTT with 75 grams of glucose, you find blood sugar of 140 to 199, that is called isolated impaired glucose tolerance. And when these two are present in one's individual, the impaired fasting glucose and the impaired glucose tolerance, you call it as pre-diabetes, and the next stage is over diabetes. So if you take this particular the fasting insulin and the after the challenge of the OGTT with 75 gram glucose, and you can clearly see the difference. Even with the normoglycemia on the left hand side, Asian Indians had lower mean fasting plasma insulin secretion as compared to the PIMA Indians. And on the right hand side, you can see following a 75 gram OGTT oral glucose tolerance test, Asian Indians exhibited a significantly lower 30-minute insulin levels. So we are running badly short of the fasting plasma insulins, as well as the after the 75 gram glucose challenge also, it is the after 30 minutes also it is reduced, showing that we are insulin deficient actually. So that is called insulinopenia. And the heterogeneous pathways of type 2 diabetes in the early natural history of the disease, that shows the emphasis of insulin resistance in PIMA Indians and the Asian Indians had 3 times less insulin secretion. This is the take home message. So how to bridge the barriers? So these are the bridges for barriers to insulin therapy. This is divided into 3 tables. The expert group recommendation says the first one is bridges for patient and community barriers. The diabetic care professionals should build trust and confidence. They should educate, counsel and support the patient, and they should practically demonstrate the technique of insulin use, and they should encourage the social marketing of benefit of insulin in the community at large. And coming to the second table, and the diabetes care professionals should empower and equip themselves with very hard skills and the soft skills and the competent paramedical staff, which is very, very important. And apart from the diabetes educators, they should have the lay educators also, and the diabetes literate and numerate patients. And coming to the last part of this particular table, so the diabetes care professionals should advocate the availability, accessibility and affordability, which is very, very important of the insulin, because affordability becomes the biggest barrier. If you write the co-formulation to a very poor patient who is an agricultural laborer, he can never afford to go for that. You should be tailor made, like one size doesn't fit all. So I always tell you that You should go according to the purse of the patient. If the patient is able to go for co-formulation, let him enjoy the benefits of the co-formulation. Where the patient is economically downtrodden, poor and all, so he can go for the biphasic human insulins. They're like our the Novo Nordisk has got that particular the human mixtard. You can go for that because that costs only 158 rupees. And the use of insulin with a lower risk of hypoglycemia, the glycemic variability, and the less weight gain. See, the classical insulin should be associated with very less incidence of hypoglycemia, very less incidence of glycemic variability, and with very less incidence of weight gain. These are the three classical important features of this particular insulin. And the use of patient-friendly insulin delivery devices, and the insulin devices we use must be very, very patient-friendly. They must be used with even a lay person should be able to dial that and take out the cap and inject again and see whether it has come to zero, and again recap it, and again he must be able to use it with use. So flexibility of time of administration of insulin is also important, and lower frequency of administration of insulin, this matters a lot because patient prefers 3 pokes when compared to 4 pokes, and he prefers to 2 pokes when compared to 3 pokes, and he prefers to a single shot when compared to this particular 2 shots. So the number goes down, the tolerance of the patient increases, and insulin they continue for a longer period. If you put the patient on basal bolus for a long period, that is 4 or 5 injections, nobody will be able to take that because it pains a lot in the longer run. See, you have to think from the patient side. And so there are very good insulins right now as of now, including the earlier we used to use in my early days of my clinical practice in this particular the field of diabetes and endocrinology. We used to use this bovine and the porcine insulins, and now they are no more existing. And Novo Nordisk has introduced this particular the rDNA genetically engineered rDNA human insulins, which are very, very efficacious and which are very, very patient friendly. And you have got the analogs, the designer insulins, and of late they have introduced even the co-formulations also. And coming to the last part of the agenda, that is simplifying the insulin therapy and initiating and intensifying, and in between there is a word called initiating, optimizing and intensifying insulin with the same insulin. Yeah, now coming to this biphasic insulin aspect, that the chemical structure of insulin, the insulin always has got 2 chains. One is the alpha chain and the second is the beta chain. Alpha chain always contains 21 amino acids, and the beta chain that contains 30 amino acids. This is regarding the normal human insulin I am talking about. So if you replace this particular sequence with like the aspartic acid in the beta chain at the level of B28, by deleting proline, it becomes insulin aspart. That becomes a designer insulin. So this is the you can on the left hand side you can see the alpha chain and the beta chain of the insulin, and you can clearly see at the level of B28, that is the beta chain at the 28 level, there is proline. They have taken out proline and they have included the aspartic acid. All are amino acids only, and so then it becomes the insulin aspart. That is, so insulin aspart on the right hand side, you can clearly see this. The insulin aspart differs from human insulin by the single amino acid substitution of a proline by an aspartic acid residue at beta chain 28. The beta 28 position is implicated in the formation of the dimers but not implicated in the pharmacological activity, and insulin aspect is monomeric at the pharmaceutical concentrations, allowing rapid absorption into the bloodstream. Here I would like to tell you that the normal insulin which is present in the bottle, I am not talking about the designer insulins or analog insulins or the co-formulations. Normal insulin, normal human insulin will be present as long as it is in the in vitro, that is in the bottle, it will be in the form of a hexamer actually. So once it is injected into the subcutaneous tissue of the abdomen, that is in vivo, when it goes in vivo, that breaks down into a dimer. Dimer breaks down into a monomer. So monomeric insulin is the active principle of the insulin. So the biodegradation from a hexamer to dimer, dimer to monomer takes around 30 minutes. That is the reason whenever you are using human insulins, you have to give a gap of 30 minutes prior to taking this food, because the monomeric insulin is the active principle, and as long as it is in vitro, it is in the form of hexamer, and it has to, like when it goes in vivo, it has to break down from dimer to hexamer to dimer, dimer to monomer. So caution is very much required. Till today, most of the doctors, most of the nursing staff, even at the teaching hospitals, I'm little bit ashamed to say this, teaching hospitals also, they are trained in such a way that the staff asks, oh, do you have the breakfast with you, do you have idlis, do you have dosa with you, then take insulin, take dosa immediately, take insulin, take idli immediately, take insulin, take lunch immediately. It will not work out as long as you are using the human insulins, unless you wait for a period of half an hour. Suppose you are using the biphasic premixed insulin, you have to give it at 8 o'clock, wait until 8:30, 8:30 you have to take the breakfast, then only it will be in the form of monomeric insulin, which is the active principle of this particular insulin, active form, so that it's going to chase the blood sugars the moment you take that. Before that you take food, it will not be able to catch up your the raised blood sugars. That leads to hyperglycemia. Hyperglycemia begets hyperglycemia. So because of this, the glucotoxicity, so all the waste products, that is the waste products, they damage the body parts. So always you think of glucotoxicity, and glucotoxicity is reduced only by administration of insulin. On the dual release insulin concept, on the left hand side you can see that the physiological insulin profile, it has got a basal component, which is the normal physiological insulin profile, which happens in our pancreas actually. The God's creation is very mysterious. We can never understand God's creation because God is unique, and my definition of God is totally different. A supernatural power which is governing this whole universe, I call it God. Maybe I call it Ram, and somebody calls it Jesus, and somebody calls it Allah, but everything is one and same. The normal the secretion of the insulin by the pancreas is divided into two parts. Round the clock, the secretion will be there by the pancreas, that is the basal secretion. That is at least 2 units, 1 to 2 units per hour, depending upon the patient profile, the person profile. The normal individual secretes 1 to 2 units of the basal insulin per hour. In 24 hours, it will be either 24 to 48 units of insulin, that is the basal insulin, and the prandial insulin, that is meal related insulin, that is whenever you take something, according to that the insulin, the pancreas releases the say equal amounts of insulin to neutralize that particular the carbohydrates or the fats or the proteins, whatever it may be, the calories that are being taken are neutralized by the required this thing. This is normal. So after we take the food only, the pancreas calculates on itself and releases the desired that is something like a targeted delivery system. But whereas in our case, what we do is the patient becomes diabetic and the patient requires insulin. We give insulin prior to the food intake, and then we take the food. That is the difference between the God's creation and the man's creation. And the second aspect is the rapid acting insulin analogs together with the basal insulin provides this particular the physiological insulin replacement. See the physiological insulin replacement, that's what I said. It should contain the basal aspect as well as the meal aspect, that is prandial aspect. So that's what it says. The second part is rapid acting insulin analogs together with the basal insulin. That makes that mimics actually. We are trying to mimic the normal the secretion of the normal pancreas. And the analog mix insulins such as biphasic insulin aspart 30 replace both meal related and basal insulin. And on the left hand side the same thing that is given in a schematic diagram, that is the graph form which I am not able to show in my tab actually. So the physiological insulin profile matches with the soluble insulin aspart as well as the protominated crystallized insulin aspart and the biphasic insulin aspart 30. And this is a schematic presentation, the graphic presentation actually. And coming to the indications of using biphasic insulin aspart actually. So initiate and optimize and intensify with biphasic insulin aspart in patients with uncontrolled blood sugars on OADs. See, I have told you the patient is on 3 oral drugs, one being metformin or the sulfonylurea or the DPP4 inhibitor or the SGLT2 inhibitor or the alpha glucosidase inhibitor, or if there is no contraindication, thiazolidine, that is the pioglitazone which is available in our country, or whatever it may be, either the GLP-1 receptor agonist. If the patient is on 3 oral agents and the patient is still not able to reach the desired fasting plasma glucose and the desired postprandial plasma glucose and the desired HbA1c, it is high time you have to initiate this particular biphasic insulin aspart. And the patients uncontrolled on the basal insulins and the patients uncontrolled on the biphasic premixed insulins and the patients uncontrolled on basal bolus therapy. And in addition to that, what I said, the patients whose HbA1c is around or more than 9%, you have to go for insulin initiation. And the patient can afford to go for this. You can go to this beautiful molecule, the biphasic insulin aspart 30. And this is about 1, 2, 3 study actually. So the patients, the inclusion criteria was the patients suffering from type 2 diabetes for a period of around or more than 12 months, whose HbA1c was 7.5 to 10%, and around or more than 3 months stable treatment regime with at least around or more than 2 OADs or 1 OAD plus basal insulin, around or it should be more actually, not less. It should be more than 60 units a day, because the cutoff point in my clinical practice and as per the evidence-based medicine, if the basal insulin exceeds 40 units, it is high time that you should take it for granted that particular basal insulin is no longer working for that patient. You need to switch over to other the modalities of this insulin regime, like either the biphasic premixed or the basal bolus or something else. So, and you can see the time in weeks, that is 0, 16 weeks and 32 weeks and 48 weeks, and it is divided into like phase 1, phase 2, phase 3. The number included in the phase 1 was 100, 68 in the phase 2, 25 in the phase 3 respectively, and they started the biphasic insulin aspart 30, that is biphasic insulin aspart 30 once a day, starting with 12 units at dinner. It may not be dinner, like you are supposed to start with the largest meal of the day. You should talk to the patient, have a conversation with the patient, whether the patient takes the breakfast as a major meal, or lunch as a major meal, or dinner as a major meal. Most of the working people, they put it as the dinner as the major meal, because in the morning they will be in a hurry to go to the office or hospital, whatever it may be, school or something else. In the afternoon also they have got some limited working lunch. In the night they have a full meal. So which is the largest meal that should be ascertained before initiating this particular biphasic insulin aspect. And preferably this 1 to 3 study, they have started this particular 12 units. And on this second thing, it was escalated to twice a day doses, that is Bisindi, that is BID doses at breakfast. It was added like 3 units of this thing if fasting plasma glucose was less than 110, and 6 units if it is more than 110. And step 3 is, the phase 3 is, they had added at the lunch also this particular biphasic insulin aspart. They have added 3 units at the lunch, that is phase 3. And at the 16th week, 21 completed the trial after phase 1, and the HbA1c was around or less than 6.5. And at the end of 32 weeks, 28 completed the trial after phase 2. The HbA1c was same. And at the end of 48 weeks, 25 people were able to complete the trial after phase 3. The 1 to 3, the mean reductions in the HbA1c in all groups, you can very clearly see in this on the left hand side. From a baseline of 8.6 of HbA1c, the 1 to 3 study has reduced in all the, like given once, given twice, given thrice, it is reduced. At the end of this study, that is at the 48th week, it was 6.6, a very desirable and a very nice HbA1c according to the goals and targets of this particular ADA or the A's or the double A's, whatever it may be. And on the right hand side, you can see this, the bar diagram, the changes in the HbA1c according to the study phase reached. Actually, the phase 1, the first bar diagram is, the A1c was reduced by 1.4%, and the phase 2, where it was given in 2 doses, it was able to reduce by 1.9%, and in the phase 3 is 1.8%. And the 1 to 3 study achieving the HbA1c targets, you can very clearly see the once a day, the 41% was able to reach the target, and in the second phase, that is taking twice a day the biphasic insulin aspart, 70% were able to reach the target, and they were taken 3 times the biphasic insulin aspart, 77% of the people were able to reach the target of HbA1c, where the baseline A1c was 8.6, and after the completion of study, it was around or less than 8.5. 6.5, sorry. And 1 to 3 study, similar low hypoglycemia rates between the phases with the biphasic insulin aspart 30 actually. So you can go through this table. The phase 1 is once a day, phase 2 is twice a day, phase 3 is thrice a day. They have given the insulin biphasic insulin aspart 30, and number of patients with major hypoglycemic events. Phase 1 it is 3 events, and phase 2 it is 3 events, and phase 3 it is very retrospectively or something ridiculously, it is only one episode was recorded, and the rate of minor hypoglycemic events per patient here, it was 15.4 with phase 1 and 22.4 with phase 2 and 12 with phase 3 respectively. And it is very surprising to see that there no nocturnal major hypoglycemic events were recorded during the phase 1, during the phase 2, during the phase 3. It was all 0, 0, 0. So the stepwise regression showed that there was no correlation between the hypoglycemia and the number of injections. So this is the greatest advantage of this particular the analog insulins or the designer insulins over this the conventional human insulins, because the major differences between the conventional human insulins and the designer or the analog insulins, they are categorized as only few differences. One is there is no major weight gain with this the analog or designer insulins, whereas you find a significant weight gain with the human conventional insulins. And second thing is you have to wait for half an hour if you are using a conventional human insulin. You don't need to use half an hour, you don't need to wait for half an hour. You can take it just prior to the meal or at the beginning of the meal. Sometimes you forget, in the middle of the meal also you can take, it works. Even after the meal you remember. I don't mean to say that you forget and take after meal every time. Once in a while it happens also. It works even after the taking the meal, because it is already in the monomeric form. That is the greatest advantage. And the last advantage and the best advantage is it is not producing any major nocturnal hypoglycemic events. Even the daytime hypoglycemic events are the 24-hour day and night, the hypoglycemic events when compared to the conventional human insulins is very, very less with this the analog insulins or the designer insulins, whereas we face a lot of serious hypoglycemic episodes at the daytime, or especially the nocturnal events are very, very dangerous because patients will be sleeping, and elderly patients, they have got a condition called hypoglycemia unawareness. Because of the autonomic neuropathy, because of the long duration of the diabetes, they don't know that they are getting into hypoglycemia, so it will not be alarming the patient. So they'll end up in coma, then they'll be hospitalized, and they need to suffer from so many problems like maybe they encounter with heart attacks, they encounter strokes, they encounter this dysarthria, and sometimes the comatose patient will not revive at all. The ultimate this thing will be death also. So until 2010 we used to say, the ADA used to say, you should welcome hypoglycemias, because whenever you get hypoglycemia you can reduce the dose. And from 2010 onwards, going with the retrospective studies, the meta-analysis what showed is the hypoglycemia has proven to be very, very, very dangerous in whatever be the patient population, let it be type 1 or type 2 or the GDM, whatever it may be. It is not at all welcome. You never welcome hypo. See to that the patient doesn't get into hypo, and counsel the patient prior to initiating the insulin, so that he takes the meal in small frequent meals, like 3 meals must be divided into 6 meals, small frequent meals, not taking 3 large meal. You should have early morning snack, you should have mid morning snack, you should have the evening snack, you should have the late dinner snack. If you take apart from the regular breakfast, lunch and dinner, if you divide it into 6 or 7 meals, the patient will not get into hypoglycemia. And the conclusions of 1, 2, 3 study. And once daily use of biphasic insulin aspart 30 enabled 41% of the patients to achieve HbA1c of less than 7 after 16 weeks. These are the conclusions from 1, 2, 3 study. And the second thing is, the biphasic insulin aspart 30 used once, twice or 3 times daily resulted in 77% of the patients achieving the HbA1c of less than 7 and 60% achieving HbA1c of around 6.5 by the end of 48 weeks. I already told you that the study lasted for 48 weeks. The phase 3 ended by 48 weeks. And the last conclusion is, in addition of a second or third injection of biphasic insulin aspart 30 provides additional benefit in terms of glycemic control with no increased risk of hypoglycemia. These are the conclusions from this particular 1-3 study actually. And now coming to the Indian clinical recommendations actually. So the RSSDI, that is Research Society for the Study of Diabetes in India, and the Endocrine Society of India, the clinical practice recommendations 2020, what they say is the guidelines. The RSSDI ASA clinical practice recommendations for the management of type 2 diabetes mellitus 2020 says either once a day dose or twice a day dose of biphasic insulin aspart 30 is recommended as a choice for insulin initiation, optimization and intensification. It is endorsed by the two big bodies in the country. And to be practical, I would like to share my experiences all the time. Don't go for either the OD dosage of this particular biphasic insulin aspart or don't go for the 1-3 study. No 3. Just remember 2. That's it. 2 shots of the biphasic insulin aspart 30 is very much sufficient. One shot in the morning and after 12 hours apart, 1 shot in the night. That will do everything. Okay. And the core message is never use insulin as a threat. So please try to avoid using insulin as a threat. Never threaten your patient. If you don't take insulin, you are going to die. If you don't take insulin, you are going to land up in heart attacks. If you don't take insulin, you land up in stroke and all. Please don't use it as a threat. You try to convince him in a better way that your body is not producing the enough insulin. So we need to take the insulin from outside. This is the way how you have to counsel the patient. And even after using so many oral drugs also, you are not able to get back to the normalcy. That means your pancreas is almost bankrupt. So you have to take, if you don't prepare food in your house, you don't starve and die. You get the food from outside. Likewise, your body is not producing enough insulin. You get it from outside. That's it. So that is the way how you have to counsel your patient and motivate towards insulin in a smoother way, not using it as a threat. And alleviate patients' anxiety about the insulin. See, patients have got lot of anxieties regarding insulin. They say once you start insulin, it's a lifetime. No way it is correct. It is a myth only. And you start insulin, you tend to put on your weight. That is also a myth. So it is not seen with the analog insulins or the designer insulins or the co-formulations. It is not at all seen. So it is a fact to some extent with the conventional human insulins. They tend to have that. Okay, and the patient goes for a regular exercise and a diet that is prescribed by the clinician. The patient, the clinician who is treating diabetes meticulously will never tend to put on weight unless the patient is on some volume overloaded state or the patient is on the glutathione plus insulin. This is the only one combination, forbidden combination is you should not combine these insulins with particularly this the pioglitazone. Actually, the only one molecule is available in India. So only the contraindication will be that, and insulin is compatible with all the oral agents, all the GLP-1 receptor agonists, all this. Off late, the oral semaglutide has come in the form of the Rybelsus in India actually. So the 3 milligram, 7 milligram, and 14 milligram is available, but it's a costly affair. I don't say that. It's not affordable to the common man at all. The cost of therapy is so high, like minimum will be like 10,000 rupees. but first of its kind is that particular there is injectable semaglutide, the best GLP-1 receptor agonist. Once in a week you can use it. The daily the oral semaglutide also has come from the basket of Novo Nordisk, and it is compatible with all the orals starting from metformin to like sulfonylureas. The insulin is compatible with all the drugs available on the globe except this rosiglitazone and pioglitazone. And insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents. I have told you 3 oral agents you have to stop. Don't go for 4th agent. You have to somehow counsel the patient and use insulin, and it is your duty to counsel and convince the patient. How you convince, it depends on your clinical experience and the level of the confidence the patient has in your this thing. And let us come to the last part, summary. So this is the take home message, and nearly 4 out of 5 people with diabetes in India are uncontrolled, and this demands timely insulin initiation. And second thing is high carbohydrate diet results in high postprandial glucose levels, which is very common in Indian reality. That leads to high postprandial glucose levels. They lead to an increased levels of glycosylated hemoglobin HbA1c, which leads to this the interference with the carotid intima medial thickness. That leads to cardiovascular disease and the increased risk of mortality from heart attacks. So the high carbohydrate diet resulting in high PPG level is very common in Indian reality, and biphasic insulin aspart is a simple and convenient choice for insulin initiation in Indians with type 2 diabetes. And the recent RSSDA and the Endocrine Society of India 2020 consensus recommends biphasic insulin aspart as a choice of insulin initiation, optimization and intensification. And thanks a lot for your patient listening. Thank you so much.
Sir, thank you so much, sir, for such a wonderful